past the hour, so why don't we get started? I want to thank you all for joining us today. And on behalf of Biotech Canada, I'd like to welcome Kyra Trainor and Marc Lafoley of Pangaea. Today, they'll be taking time out of their incredibly busy schedules to share their insights on drug supply issues in Canada relating to COVID-19. So thank you both so much for being here with us. And I'd like to remind our viewers here that if you have any questions during the session, please type them into your Q&A feature that you'll find in the menu bar at the bottom of your Zoom window. And we'll do our best to get to them at the end of the presentation. So with that, I'll mute and hide myself and hand it over. So go ahead.
Great, thank you very much, Emily. Good afternoon, everyone. Just wait for the deck to come up. So today what we're going to be talking about, certainly I think we're all living through unusual times right now, but some of the things that we have experienced, there's some challenges within the supply chain for drugs in Canada. And our talk today, we're going to focus on a couple of things. Kyra, if you can just move the slide down, please.
So what are you saying? Oh yeah, you're in control. I've given you control, Marc.
Okay, I'm pushing, it's not coming down.
Okay, so hold on, go there.
Okay, there we go. So what we're going to do today is we're going to give you a brief overview of who Pangaea is. One of the things we're going to talk about, and which was one of the precursors to this whole issue, was stockpiling. We certainly saw it within the consumer media, but some of the stockpiling that went on with medications as well. Then we'll give you some background information on the whole supply chain within Canada. Then I'll pass it on to my colleague Kyra, who's going to talk about the strategies that were implemented and what those impacts were on the whole drug distribution system. I'll talk about some risk mitigation strategies and some potential for future considerations, which you may want to take into account in the event, hopefully not, but they are potentially speaking about a second wave of the COVID-19 virus.
Is it going down? Okay, I'll just say next slide then, if it's
okay,
not.
Next slide, please.
I'm gonna...
Okay, just before we get into this, I would just like to offer a little disclaimer here. And the whole point of us doing this, it's a retrospective analysis. We're not here to pass judgment on anything that was done, but it's really more for us to observe as to what happened and how we can learn from it and how we can avoid should we have other future force majeure that may impact our industry. Next slide, please. Just tell you a bit about Pangaea. So Pangaea was founded more than 25 years ago. It was founded by Joe Knott, which is in the middle left of the screen. We're a boutique Canadian consulting company focusing solely on healthcare. And we solve business challenges that are unique to Canadian pharmaceutical and biotech businesses and their partners. We have three pillars, which are outlined on this slide here: corporate strategy, business strategy, and trade strategy. And what we'll be focusing on today is the trade strategy. Next slide, please. So from a trade strategy, we have a group of trade consultants that deal in the day-to-day for national trade relations. We manage more than $2 billion in RX and OTC sales in Canada. We're the second largest player for managing brand pharma's distribution channel. And over the last 5 years, we've assisted 50 clients with their trade deployment. Now, I'm going to get into the psychology of stockpiling here, and today is not my plan to give you a psychology lesson. I'm a business marketing major, but I think it's important to put some perspective in here. Next slide. That explains some of the behavior that we have seen. So I'm going to review Maslow, the classic in sociology. Maslow's an American psychologist. This is one of his theories that he published in the mid-40s. And essentially, it's pretty simple. at the time, and it's held through the test of time, but it really says that needs at the lower end of the hierarchy need to be satisfied before you can move on to the higher end. Now, generally in North America, we take for granted the physiological and safety needs, and we focus on our social connections, which are love, relationships, family, self-esteem, and self-actualization on the top part of the pyramid. But if we look at what happened, starting at some point in February, I'll say mid to late February, we're starting to get cues in the marketplace that we're having people question their physiological and their safety. And if you can just, next slide, please. So just look at some of the verbal cues. And I just took a couple here. We could have filled up this page with many more than this, but I mean, just look at what's highlighted in red. It's really about first of all, making sure that you do have enough to survive. Canadians should continue to think about ahead and what they can do and what they can take to stay healthy. There's a high likelihood that there will be drug shortages related to COVID-19. If we move on to some of the written cues that we were seeing in, either on the web or in the press, don't just rely on drugstore for medical supplies. The CDC says to stockpile your meds. Here's tech to help. And on the government website on the right-hand side here, I've highlighted some areas in blue here, which talks about refill your prescriptions, renew your prescriptions, fill your cupboards with dry goods, and I highlighted toilet paper. I think a lot of us saw that in the news. And then if we move on to the next slide, we'll see what the visual cues that we were seeing here, either in the news or even when we were out and about. I mean, this was famous in the news with Costco, people filling up carts, filling them up with paper towel and toilet paper. The older gentleman here, this is a gentleman from Italy. So we were seeing what was going on in Europe, and he was lamenting that he went to the grocery store and there wasn't any pastas on the shelf. If we were in the stores, we saw empty shelves of toilet paper, empty shelves of pasta. And if we look on the top right here, we see canned goods where there was a run on canned goods. In addition to that, we were warned that we should stock up on analgesics in the case that we do catch COVID-19 and we need to control the fever. Or if you're looking at pharmacy shelves, there was a run both on ibuprofen and acetaminophen. Then it was in the press, it was said that ibuprofen was not potentially not good for treating fever and COVID-19. So then acetaminophen had a run. So all of these things lead to a behavior where people are trying to fulfill their physiological and their safety needs first. Move on to the next slide. I mean, everyone's going to do this based on what the perceived level of risk is. And generally, people will react when they feel that there's going to be a scarcity, and that's going to lead to people stockpiling. When I talk about stockpiling, I'm not talking about hoarding. I'm talking about people in preparation for the event that something will no longer be available. Now, the big danger in what happens in the supply chain is that when stockpiling plays out collectively. And we're not talking 100% of the population. We're talking a small percentage of the population that ends up stockpiling, that ends up creating a shock to the supply chain. Next slide, please. So just going to give you a bit of background information on the drug supply chain. So next slide. I mean, what we'll see is the supply chain is efficient, and through the years, it's been globalized. So we have raw materials, about 80% of those raw materials are coming from China. Manufacturing, a lot of the generic products are manufactured in India, but we also have for centers of excellence around the world for a lot of the brand name drugs where you have one plant manufacturing the drugs. We do have some that are manufactured here locally, but usually, again, these are centers of excellence that are also involved in exporting product. In any case, whether it's produced locally or imported, it comes into the Canadian subsidiary, and then it goes through the supply chain here within Canada, which is either self-distributing retail or wholesalers, and then makes it through the main channels being home care, retail pharmacy, long-term care, hospital, or specialty. I mean, the modern supply chain, it relies on just in time. So production schedules are tailored to demand. So that the main reason there is to bring efficiency into the system so that we don't have unused stocks sitting in any warehouse. And it is a finely tuned system that's geared to efficiency. Now, there are occasions, we have lived this over many years, next slide please, where we do have drug shortages. So there are drug shortages in Canada, and there's a system in place that was put in place by Health Canada and industry together, where we would report either potential or anticipated drug shortages, or report on actual drug shortages. So the tier 1, tier 2, and the concern is always actual drug shortages where there's no alternative. I mean, if you just take a look at it, there's over 1,300 molecules in place. I just took a review of the drug shortage website, and we have 15 molecules that are experiencing a shortage. So it's not the hundreds and hundreds of molecules that are experiencing shortages. But what happens, next slide, please, is, as I was mentioning before, when you start having a group that starts collectively stockpiling and starts buying up, it does create a shift in demand. So what we did here is we just took a fictitious product, modeled it out, and if you look here, is we look at 2 million units a month, and you're with a growth that mimics the population. So you see a nice gentle slope, and normally that's how demand should be. It should month in, month out, it should pretty much rely on what the consumption is. As I talked about earlier, when you start having the cues in the marketplace that start talking about potential for shortages, you will have a percentage of the population that will start perceive that as a risk to their safety, being their health, and will start stockpiling up on the medication. Now, what we did here is we modeled out different levels of consumers that would be stockpiling, what the impact would be. So if you look at the red line is if people start forward buying 3 months in 1 month, 15% of the patient population starts forward buying. The blue line is if 35%, and obviously the highest one is 50%. And you just see what the impact is. I mean, if you look at the impact at 15%, it's about a third higher. If you look at the impact at 35%, it's almost 60% higher, and then it's more than doubles when you have 50% higher. And then so you have that peak, and then afterwards you have valleys. So it is creating a shock to the system. And I think, you know, one of the things that we have seen from the COVID-19 experience is not that we've run out of drugs, but we've had some challenges in responding to demand for stockpiling drugs. The highly efficient systems, they just don't have any slack or redundancy built in. And this is one of the things that we noticed that occurred during the period of March and April. Next slide, please. What ends up happening is we just look here and we model. This is Pangaea estimate as to the share of the different wholesalers and distributors in Canada. And what ends up happening is when you end up with a shock to the system like this, is all of the players, and none of them can respond to this kind of these kind of rapid increases in demand. One, because they're not anticipated, and two is we just on the previous slide we were just looking at the example of one molecule. Now imagine this happening on hundreds of different products and hundreds of different SKUs. It becomes untenable to manage within the current distribution system. I'll now pass it on to my colleague Kyra, who's going to talk to you about some of the strategies that were implemented and what the impact was.
Thank you, Marc. So thank you. I'm going to touch on 3 areas basically of policies that were implemented. And let me say, as our group, was very busy 3 to 4 weeks, and I've certainly never seen anything like that, even as it related to SARS. This was quite unprecedented on what happened. So it was really good for us to reflect afterwards to see what could we look at in order to learn from it and then move forward to see how we can advise our clients moving forward. So the three areas that people actually implemented policies were at distribution level, at the retail level, and at the manufacturer. And I'll go through each of those. So I wanted to share with you some of the things that we were observing during this time on the distribution side, so the wholesale side. In early March, I would say even in late February, we started to see buy-up signals with some of our clients as it relates to certain areas that would be high demand for COVID-19 related illnesses. It was subtle, but it was coming. And if you think about it, I mean, I relate everything to Ontario only because of when it happened. We were literally going into our spring break, our March break with the kids. And so we started getting travel advisories across the country around March 13th to 20th. So there was different advisories, different notices coming. During that same week, we started to get allocation notices from distributors, so putting products on allocation. As the heightened awareness and these visual cues and these written cues and verbal cues all came out, that the psychology of it that Marc had just described happened, we saw increased buying up. And then what happens is then distributors have to react. So on March 17th, we learned and we knew that McKesson actually ended up putting all of their clients on daily supply. And this is quite interesting and quite critical. And it's basically they shut off the faucet. So it's a quick way to do it until they can get their analysts and get a better sense of what's happening. And so what they did was, if you can consider, let's look at a retail pharmacy that might on average order 10 units of a product for a week. You think, okay, 10 units, that means daily, that's going to get you 1 to 2 units a day until kind of that you hit that. So it actually, what it does when you're on a daily supply, it averages up, because you can't ship 1.5 units or 1.7 units. So it will average it up. So that actually puts further pressure on the supply because you're increasing demand due to that. So each retail pharmacy was only getting what their allocated amount was on a daily basis, which also drove up, obviously logistics with the McKesson, because they would have had to make deliveries. Well, they have to make deliveries in most areas twice a day anyways. So then what happened is the week after, they were able to, so while this was all happening on the daily, a lot of the retailers or the pharmacies actually have a secondary wholesaler that they would use. Not all of them do, but most should. And this is an area that you would actually see where you would actually need a secondary wholesaler. So if you can't get it from your primary, and as we saw earlier, McKesson is the largest market shareholder, then you go to your secondary. But then what a lot of the wholesalers were doing during that time was, if you're not my primary, so Mr. Pharmacy, if you're not my primary, then I'm not going to service you because I have to take care of the ones that are my primary. So you started to see this, basically people could not get product anywhere in the system just due to the demand out the door from patients. So then by March 23rd, McKesson did go on weekly allocation, which really helped alleviate certain things, but you're still only being able to order those 10 units on that week. And we know, based on what you saw from Marc's graph, is that it's not taking into account people that are actually stockpiling. So if you were averaging a run rate of 10 units per week on a weekly allocation, and then you have a huge influx of people over the course of a week or two come in, it's still not going to meet the demand. So then what happened, and this I'll get into a little bit later, by the end of March, in early April, we were able to start getting at least certain products that we knew clients were not going to be on back order for off allocation once the teams got caught up. But when you think about that peak of kind of March 13th and even into March 25th with the allocation, essentially what we knew was happening was there was really nothing in the system. And when we say that, there was nothing at the pharmacy level and there was nothing at the wholesale level. It was just basically cleared out. So everybody was trying to get the few products that had. Manufacturers were obviously trying to ship, but the logistics of it is it just takes time. We did hear of you know, obviously people that, you know, like the types that would buy 500 cases of toilet paper. We did hear of cases like that at the retail level, but it was few and far between. Most people had nothing in the system. It was empty and they were trying to get it for the patients at the front line, which creates panic, and then further media coverage and further buying. So this was an interesting kind of survey that was done out of Manitoba. And what was the reality for pharmacy during this time? Because you could say, well, didn't pharmacy have stuff on the shelves? And actually they didn't. Only about 7% of respondents of this survey actually got the medications that they were ordered and received them. Most of the time they were unavailable due what they termed wholesaler or manufacturer, and we can talk a little bit about that, or restrictions imposed, or more so restrictions or shortages identified by wholesaler or manufacturer. In a lot of the cases, there were not shortages. As Marc had said, there's only a few molecules that, well, there's molecules that are on back order, but the system and logistics wasn't catching up to it. And we'll talk a little bit about this as manufacturers and how they directly communicated this, this issue that was happening in the system. So if we now look at what, that was what the distribution or the wholesale channel was doing. If we look at what retail was doing, they actually looked at it and said, we need to implement some policies to protect supply. So typically you've got 90-day refills in the system, but they went to actually 30-day refills and started creating policy based on the provinces. And this further creates chaos and understanding, well, a bit of chaos in the system, because every province implemented something different and policies were changing constantly. So if you look in the first kind of column, these were the provinces that actually implemented the 30-day refills. And then you'll see in the far right column, the ones that have actually already reversed their 30-day refills and gone back to 90. But then to add on top of that, there was confusion in the system because not all governments were actually paying for the 30 days because essentially that would have, it was driving up cost. So that cost of the prescription refill at 30 days was borne on the patient. So as you can see, as we have a hodgepodge of health systems across the country, we had a hodgepodge of different policies rolling out in the system. So to relook at this, and why I wanted to bring this graph up as well, is that what this has done with the 30 and 90 days, difference by province, understanding what was actually true demand versus what's stockpiling demand, it has created such confusion in the system that manufacturers are having a hard time understanding the data that they receive, either through IQVIA or the data they get from their wholesalers and their retail partners, because you don't truly know. It's very hard to interpret what is kind of people stockpiling that they'll eventually use their medications, or is there new starts in that system, things like that. So once again, that goes into how you forecast and demand plan, and it's very difficult to do when you start having blips in the system that are not normal. So with any policy change, can be negative implications. And if you take a look at even that 90-day to 30-day policy change that happened in the majority of provinces, what you actually see is that for the pharmacy, this created 3 times the amount of work. So they were still having to fill the prescription, but they have to do it every 30 days. And so they were also, with COVID, having they saw an increase in cost as it related to home deliveries, because nobody wanted to come in every 30 days because they, especially seniors, people at risk, they didn't want to come in to get their medications. For patients, it was increased risk walking in if they decided to do it with 3 visits, but also this was driving cost, especially if the government wasn't paying for it, with having your renewal that you'd have to pay, or your co-pays every time. And then finally, the government, when they implement these policy changes, or the associations do, the increased cost is borne to the taxpayers, because if they are kind enough to pay for it, then they're going to have, then we end up, which is good, ended up getting it covered for patients, but it eventually falls on the taxpayer's dollar. So the third way that we could control things in the system is via the manufacturer. So we talked about what the distributors did. We talked about what the retail pharmacy ended up having to do through government and association policies. But manufacturers ultimately control allocation during supply shortages. It's up to them on how they want to release product and where they want to ship it. So every manufacturer should have their own method of allocation, and it all varies by manufacturer and how they address that problem. And it can be based on, you know, how much product's coming, when the next shipment is coming for replenishment. One of the things we did learn during this crisis was that you needed to monitor your shipments very closely and your orders, because there was so much kind of chaos in the system. Unfortunately, what we did observe at times was a shipment would have left a building, either maybe got to the distributor, it could have sat on the loading dock or somewhere in their warehouse without being received, but the system would trigger another order, which then compounds like the issue of not having enough supply in the system and then not knowing where that supply is. So that was very important for manufacturers anyways to monitor their orders that were going out, and then making sure that those shipments were tracked. So critical to the manufacturer allocation, it's very important that any allocation system be fair. And I think anytime we were talking to distributors during this time, that was their kind of one message, is we just ask that everybody, all the manufacturers, are fair in the process and how they allocate, because everybody wants their kind of, we'll call it, fair share. As well as when you're looking in the height of all of this, you have to have a system that's easy to implement and easy to monitor. And then it needs to be reassessed constantly. I can't tell you how much new information was coming in on a daily basis during that kind of 3 to 4 week period, with new policy changes and everything like that. And then of course, the biggest thing is how you communicate it to your stakeholders, to your distribution partners, to your pharmacy and retail partners, and then to patients. And what we did see was a lot of manufacturers were going directly out to retail through pharmafaxes to say, we are not on back order. You know, we are fully stocked. It's just a matter of getting it through the system because the shelves were empty. So this is a nice picture that talks about, I think there's a couple things to look at. The demand index is kind of where we see demand within the system on a regular basis. And then what we saw in March, we saw basically a 29% increase in demand in March. And then in April, we actually saw a 36% decline so far, or what we saw in the system. So demand kind of in March has, or the decline has outweighed the demand in March. And as you can see, kind of going along with that is how people were receiving their messages through the media and their search activity that they were doing. So we still have to get kind of main numbers in to see where the system is. I think Pangaea would say net negative. I think this system is, or the industry is probably down. And we've certainly talked about this because we know that patients are not going into their doctors. They might not be starting new medications. They may not be filling their prescriptions because they now have been laid off and they no longer have private coverage. So there's a lot of things in the system, but this is kind of how we see it. So if we're going to talk a little bit about risk mitigation, and I've touched on a little bit, but I will highlight on a few things on going forward, some of the things that manufacturers can do, as well as wholesalers and retailers. So from the manufacturers, I think it's going to be very interesting, and Marc did touch on this, about the active pharmaceutical ingredients, so the API. I think this has highlighted the somewhat the issues with globalization. We know that the most APIs are made in China. So what are manufacturers going to do, and what are governments going to do to try and risk mitigate that in a case of another kind of mass scale pandemic, or even how we address this over the next 18 to 24 months? What kind of safety stock are you keeping within country, and what kind of safety stock are you keeping above country? I think that's very important because, as Marc said, a lot of this stuff has been just in time, and that might need to be evaluated. How good are you at your sales and volume forecasting? Do you know your historical data? Do you know what your forecasting is? Because that's going to drive your demand, and know how much you're going to bring into country. One of the critical things, and certainly what Pangaea does well, is we have obviously our partner network with all the distributors, and understanding and who to go to when there is critical issues. If you are not maintaining a close relationship with your distributors, it's something that you should be doing. And I think this pandemic certainly highlighted where there might be, where relationships might need to be strengthened, certainly from other manufacturers. Communication strategies, so how you're communicating what's happening in real time, and then just in general partner engagement. From a wholesale level, this was kind of interesting. I'll focus on point number 2. I call this the perfect storm, and we've talked a lot about this. In actual fact, March end was there was a number of forces in the happening already on top of COVID. So McKesson's year end is March. Now I can't say for sure, but I would add the question would be, typically at a year end of a distributor, are they drawing down their inventory, not having as many days on hand just to get ready for year end? Were they kind of running a little lower? I don't know, but March, certainly March year end was happening for our biggest distributor in the country. As well as for governments. So hospitals, typically you see a buy up in March, because if they do have extra money in the system, they might spend it on pharmaceuticals before their year end is happening. So you might have even seen a change in demand there, as well as price increases across all the governments. A lot of the governments were in play. So you typically would see an increase in demand at the end of March for people wanting to realize lower costs before the April 1st price kicked into play. So wholesalers, obviously, there was a whole bunch of other things that were happening at that time during COVID that were kind of critical to developing a perfect storm. So with wholesale, the other thing we really kind of saw and was critical is that how important their own dedicated resources are. When you've got billions of dollars of products sitting in warehouses, you can't necessarily have untrained staff coming through. So their staff, and being able to manage if staff got sick, or if they were, if they had an outbreak internally, was top of mind, certainly for wholesale. And although these folks work in a warehouse, they are qualified staff, and they need to know how to move product, and it's an expensive product to move. So that was critical as well. I'll touch on a little bit, there's other points that you can see there. Frontline. This was interesting because, of course, we have frontline retail pharmacy, but we also have banners that you deal with. So how is that communication from the retail banners going out to the stores? The 30-day notice, and how are you dealing with objections that are coming from your patients on 30-day, or even on product that is not available on the shelf? And then how are you getting that product through the wholesale, and understanding what the manufacturers actually have. The alternative drug awareness, obviously if one product you can't get, you have to understand what an alternative is for that patient. For the manufacturers, this is actually a really kind of, what I want to say, a terrible thing when your shelves go bare, because especially if you're not on back order and the shelves are just empty, what can happen is you see a lot of switching during this time, and that's just painful as from a manufacturer to watch, because you work hard to make sure that that patient is on the product and managed well, and unfortunately shifts do happen. Cases happen where there isn't an alternative, but I understand those. But in this time, there could have been a lot of switching that you just can't assess at this point. And then dedicated staff. Unfortunately, retail has gone through a lot of, we'll call it harder policy changes, which have kind of diminished staff a lot at the pharmacy level. So having dedicated staff and understanding how to crisis manage this is very important, and managing through that. So these are ways that retail and frontline can mitigate drug shortages or the impact of them. I'll just move forward to potential for future considerations in my last slide. Our last slide. So just looking at what we kind of predict coming down, and some of the things that you may want to consider is that ongoing supply challenges due to distribution and logistics challenges. I think the number one thing that our manufacturing partners and clients are concerned about is the lack of air cargo right now, because that's getting it harder and harder for product to come into country, and getting flights secured to move product within across the pond or wherever it's coming from. I did talk about, and so did Marc, the shortage due to API. I think this has to be really thought about on how the industry addresses this in the short term, long term, and even how government wants to address this. The other thing to consider is that Ontario has not come off the 30-day allocation. Ontario is about 40% of our population. Once that comes off a 30-day allocation, is that going to rush people in to purchase more products? What kind of buying behaviors are we going to see from that? Is the system able to absorb a 90-day supply once the 30-day comes off? Another one is just as it relates to kind of hospital tenders and other things like that is, would there be consideration for price premiums for domestic supply, even in the short term? I always say that government's the kind of one of the ones that might forget in the longer term to go back to the lowest price cost. But is there going to be considerations if there's price premiums or something, not necessarily with pharma, but even with med devices where you have a domestic supplier that might have a higher cost, but at least you know in cases like this that you're going to be able to secure the product locally. And then the last point is everybody's talking about wave 2 in the fall. So what's going to happen with wave 2 and what kind of psychological buying patterns are we going to see? And is the industry ready to deal with that in the I guess the shorter term as that unfolds over the fall? So I'll stop there and I will put that slide up and Marc and I can address your questions.
Thank you so much both. And just a reminder to our guests that if you have a question, please go ahead and type it into the Q&A feature that you'll find at the bottom of your screen. So we'll give you guys just a minute to do that. Now, sometimes we do have kind of a shy group, so we'll see if we get any questions, but we can always get them sent over to the speakers afterwards if anyone thinks of any questions at a later time. All right, well, I haven't seen anything come in, so I guess we will wrap there. I want to thank you both again so much for your time. I know you're both incredibly busy right now. And, oh, sorry, I spoke too soon. We've got a question. Here we go. Okay, first question. We experienced pharmacies seeing message MCS and figure cannot supply in WS systems, yet supply was readily available. Do you see one outcome from this? This is enabling better transparent technology at WS. That makes sense to you?
Mute. Yeah, so we actually, a number of times actually, we're trying to get some of the messaging, because every message system, and I apologize if I'm not 100% sure about MCS, MFGR, but what we do know is in notice boards within retail and at the banner level, they would be getting different notifications. Not all manufacturers are privy to those notifications. We often hear about it through customers or patients. So it's just one of those things that you kind of have to dig a little deeper. And we would, you know, oftentimes even Pangaea would be calling pharmacies just to see where their clients' products were at and what kind of messaging that we were getting. I'm not so sure if, yeah, I'll have, as it relates to better technology, this is where it's important to communicate as a manufacturer at all times as well. If you're seeing that, and I'll take it from a manufacturer's perspective, if you're seeing that the message isn't resonating to what your reality is, that's when you might want to consider doing your own message out through pharma faxes and things like that. At the end of the day, what's being messaged through from the wholesaler to the retailer, or the retailer to, or the banner to the retailer, can be many, many different things. And we don't always have visibility on them. I hope that answers the question. I'm not sure, but Marc, did you want to add anything to that?
No, I think that's fine. We might just need to get a couple, need to understand the MCS and the MCS part of it. So no, that's fine, Kyra.
Yeah.
All right, there was one other question. What type of costs are involved in the switch from 90-day to 30-day prescription policy changes?
Well, yeah, I guess we can both kind of jump into each other here, but this is going to take place at multiple levels. So if you take a look at the level from a wholesale level, I mean, the cost is you're going to be tripling the number of deliveries that you're going to be making to a pharmacy. So that's from a wholesale level. From, as Kyra brought up during her presentation, it's going to increase dispensing fees, or the pharmacy was going to have to absorb those extra dispensing fees depending on the province and the policies. And the other thing as well is just think about all the extra time for delivering product as well to customers, to their homes. Home delivery shot up tremendously. I don't remember what the percentage is, but it was well overweighted compared to the increase because people just didn't want to go to pharmacy anymore.
Yeah, I think, yeah, exactly. For the net negative of, or the net cost really is, the end of the day, there's a lot of co-pays, and it depends on the plan you're on. But at the end of the day, if you're only refilling every 3 months, and it's call it a $10 prescription cost to refill, think of that at 30 days, you're paying that $10 3 times over. And so sometimes the government was picking it up, but not often that they were. So, and it depended on how percentages, and Ontario had come out with a plan to do kind of a tiered pricing that they had proposed. They ended up not doing that, but that's where you can see there was just, even 2 weeks ago, communication in the system on just really understanding what those costs were in the system. But at the end of the day, a lot of it, the costs were put to private plans, if the private plans would absorb that, or to the patient having to pay that out of pocket.
Great, thank you both. That's all we've got for questions right now. But again, I'll invite all the guests to send them in to me, or you see the speaker's contact info up on the screen here. We can definitely make sure your questions get answered. So thanks again for joining. Kyra, Marc, again, thank you for your time. This was great. We had a wonderful turnout, over 30 guests on the line today, and then the session will be available on demand on our website after. So thank you both.
Thank you.
Good, and with that, I will end the call right now.